Hello, I'm Christopher Todd Anderson. I am a clinical neurologist and epileptologist. I am director of the Epilepsy Monitoring Unit at the Hospital of the University of Pennsylvania. I am also co-director of the Epilepsy Surgical Program at the Hospital of the University of Pennsylvania, along with Gordon Baltuck, our epilepsy neurosurgeon and specialist in deep brain stimulation. Deep brain stimulation has been explored for decades. Over the past 40 or 50 years, there have been many small trials, some of them uncontrolled and using small numbers of patients, to see if stimulation of deep brain structures would help patients with refractory epilepsy. Only within the past 5 years has there been a large-scale, double-blind, placebo-controlled, randomized trial for deep brain stimulation for patients with epilepsy. The reason why this is being explored is because there are many patients who have epilepsy who are refractory to medical therapy and who also are not good candidates for traditional epilepsy surgery, which involves resection of areas of the brain where we believe seizures come from or propagate. Deep brain stimulation has been very popular and successful for movement disorders. People have been attempting to apply this technology to other neurological diseases, and finally, we have results recently that show that this technology is applicable for patients with epilepsy. Over the past 5 years, there has been a large trial sponsored by Medtronic looking at stimulation of the anterior nucleus of the thalamus for patients with refractory epilepsy. This has been known as the SANTI trial. SANTI is an acronym for stimulation of the anterior nucleus of the thalami for epilepsy. Historically, people have stimulated other targets in the thalamus in an attempt to control epileptic seizures. These include the centromedian nucleus of the thalamus, as well as the anterior nucleus of the thalamus. The SANTI trial is unique in that it was a well-designed trial. It was a prospective, double-blinded, multi-center, randomized trial designed by, among other people, senior investigator Dr. Robert S. Fisher. The study design was as follows. Patients were eligible for the trial if they had refractory partial onset and/or partial onset and generalized seizures. They had tried 3 or 4 standard epilepsy medications. Some of them had tried other therapies for epilepsy, including vagus nerve stimulation and/or traditional epilepsy surgery. They were followed for 12 weeks to determine their baseline seizure frequency. They had more than 6 seizures per month. Many of these patients had severe forms of epilepsy, including frequent complex partial and secondarily generalized seizures. At the time of enrollment, they were determined to be eligible for the trial. They were followed for a baseline phase, as stated, and at time point 0, they underwent implantation of bilateral stimulators to the anterior nuclei of the thalamus. These are quadrupolar brain stimulators which are connected to a Medtronic implanted pulse generator which resides in the chest. So here we see a depiction of a person, and the 2 globular egg-shaped nuclei deep in the brain are the thalamus, and these are essentially relay stations in the brain for afferent input to other areas of the brain. And you can see that there are 2 electrical stimulation leads implanted in the anterior portions, and they are connected to a pulse generator which resides in the chest. The pulse generator is similar to the pulse generators used for patients who have deep brain stimulation for movement disorders. For about 70 years, we in the neurological community have believed that there is a circuit called the circuit of Papes. This is an important circuit for memory function, and it runs from the hippocampus in the mesial temporal lobe and has projections to the cingulate cortex, as well as to the mammillary bodies and to the anterior nucleus of the thalamus. Whenever a seizure happens, regardless of where it starts in the brain, if it gains access to this circuit, it is very likely to propagate widely through the temporal lobe and also throughout other areas of the brain. If you can intervene on abnormal electrical activity within this circuit, you may be able to disrupt the propagation of a seizure. So the study design was as follows. Patients were enrolled. Their baseline seizure frequency was counted for 1 month, and then they were implanted with bilateral quadrupolar electrodes to the anterior nuclei of the thalamus. Initially, approximately 150 patients were enrolled, and 110 finished the study. Patients were randomized to the stimulators being on or off for the first 4 months of the study. Over the first 4 months, seizure reduction was tracked monthly. At months number 1, the non-stimulated group had a reduction of 25%, and the stimulated patients had a reduction of 33%. At month 2, the non-stimulated patients had a reduction of 28% compared to the stimulated patients who had a reduction of 42%. And at month 4, the non-stimulated patients, their seizure reduction tended to decrease towards baseline, and their seizure reduction regressed to 14% improvement, but the stimulated patients had an enduring positive effect on their epilepsy and had a continued response, and their seizure reduction was that of a 40% reduction in seizure frequency. More important, over long-term follow-up, when the patients were evaluated at 1 and 2 and 3 years after implantation in the open label portions of the study, there was a median reduction in seizure frequency of 41% at 1 year, 56% at 2 years, and 68% at 3 years. The pre-market approval application was submitted in June 2009 and is currently under review with the FDA. I cannot give any predictions about what the FDA will decide, and I cannot give any predictions about if or when the device will be approved. I would like to make some emphatic statements about the future of this device in the context of the patients that I take care of in clinic. I see a lot of patients with severe refractory epilepsy, some of whom have tried virtually every medication available, who have had epilepsy surgery that didn't work, who have tried the vagus nerve stimulator, who have had invasive monitoring to localize their seizure onset zones, and have virtually no options left. They come to me and ask me on a regular basis, I have seen this device mentioned on TV, in the news, when will it be available? I now believe, based on a well-designed study, that the device works. I believe it's safe, and I think it would be essentially a travesty if this device is not approved, because I have patients for whom it is appropriate. The market for the device, meaning patients, is there, and I feel in a very lucky position here at the University of Pennsylvania, working with Dr. Baltuk, who is one of the world leaders in deep brain stimulation. I feel poised to offer this device to patients should it become available, and I look forward to that.